Brilliant. Thanks, Sean. Thanks for the introduction. Thanks for inviting us to talk on a webinar. We're going to talk on infection, obviously a very important topic, something that we're all challenged by a lot. We're very lucky as arthroplasty surgeons to do a fantastic operation, but of course infection is always lurking in the background there to make our normally very happy lives somewhat miserable. I'm joined by my colleague Hussain from Crewe, and we're going to talk a little bit about infection, particularly in respect to PJI. So I'm a consultant arthroplasty revision surgeon in Northumbria in the north of England, and we have quite an interest in infection. We've got a bone infection unit, and I'm also heavily involved in the Bone and Joint Infection Registry in the UK as the treasurer, along with Mike Reed, who's our chairman in Northumbria, and I will be giving you a bit of an update on that at the very end of the presentation. So we've titled it Infection, the Arthroplasty Surgeon's Worst Enemy. I'm sure most of you that are involved in arthroplasty would agree with that. Why is it such a problem? Why have I labelled it as such? Well, people always talk about the huge cost of infection, and they usually talk about that in financial terms. So we know obviously that infection is extremely expensive. It's expensive to treat. Patients require multiple operations. It's expensive to the patients. And Ashley Blom published a paper just this month in a BMC journal talking about the actual financial cost of that. But to be honest, from my point of view, I think the biggest cost with infection is actually much more psychological and emotional. And that's, of course, of the patient who's having to go through the terrible processes that is having an infected joint replacement and the multiple surgeries that entails, but also, of course, their family. And actually, there's also an emotional and psychological cost to the surgeon and, in fact, the whole surgical team. Hearing that you've had an infected joint replacement is not a happy place, and it's a difficult thing for everybody to deal with. So it certainly, I think, is the enemy. So on that basis, I'm just going to start this evening with this short video. It's only 4 minutes, do bear with it. It actually starts off just with a lady having a knee arthroscopy, actually, but it's very reflective of the terrible experience that patients go through if they get infections. So I'll just play the video and then we'll carry on with the rest of the talk. So here we go.
Came into hospital at 7:30 on the 23rd of December 2016 because I was having problems with my knee because it kept giving away, and just went down to surgery as pre-planned. Everything was fine and good. I was discharged feeling absolutely fantastic, bouncing because I could feel my knee for a change and it wasn't giving away. Went home. I'm always rubbish after any anaesthetic, and I just said I felt a bit tired, went to bed. Christmas Day, I woke up feeling that something wasn't quite right. Tried to walk on it, couldn't put any pressure on it. Went back to bed. The next day, 26, I woke up and I knew something was wrong. So I asked Keith to phone 111, basically, and that's when the paramedics came out. We got put into A&E. A doctor came and had a look at it, and he says they asked an A&E nurse to sort of like get the needle, because try and drain some of the, presumably, infection, what it was, or take the swelling down. They put a needle in, and he looked at the colour of the syringe, and he says, you have to go down to theatre straight away. I was in hospital for 3 to 4 weeks, had about 4 to 5 operations. I just didn't really remember what was going on at times, because I think you just sort of like go with it. Your mind's elsewhere, just wondering what's wrong with you. Very difficult, very difficult. I'm quite an independent person, and to have somebody to sort of do everything for you. Keith lost his job because he had to give the time up. It was just a horrible, horrible time. They were just so worried. They were just stopping. It had a massive impact on our relationship. It put a lot of strain through it. It was just a horrible time. It was difficult at home, just because all the bathrooms were upstairs and got nothing. Just getting up and down, I had to have a wheelchair. I couldn't go to work, which my life was just turned literally upside down. I still haven't got the bend that I thought I would have had with a knee replacement. People are different towards me. At work, in general, my friends are different with me because I can't do the things that I used to have. I don't go out socially like I used to have. Having all what I've been through has totally changed me as a person. I was bubbly, sociable. I used to swim every day. I used to walk every day. I used to go out and enjoy being in for a drink and things like that. Being with my family a lot more and just generally have a real good time. A bit of a party animal, that's what I've been told I used to be. But now, since my knee operation, I just don't want to go into a pub. I'm not interested in going out. I've actually seen a counsellor because of my knee replacement, because I just didn't quite understand how I came from having just a normal knee operation to how it's come. It screwed me up big time. My life has changed big time. I'm not the outgoing person I used to be, the confident person I used to be, because of my knee replacement now. I've got more operations to come in the future, which I'm not looking forward to. But that one infection can change somebody's life, which could kill them or end up like I have. So please just be careful, extra careful.
So a little bit of a somber start maybe, but actually I think really drills home the huge problem with infection. And that's the real cost to my mind, and why we really need to give infection such a degree of energy and thought. So that's the cost of infection. And why else is it so difficult? Why else is it our arch enemy? Well, the fundamental problems with infection are that certainly sometimes it can be pretty hard to diagnose, and certainly hard to diagnose properly with all the information that we need to perform the next step, which is, of course, the treatment. And it can be very hard to treat. We'll all know stories of patients who've had multiple operations for infection that haven't worked out. And for these reasons, it really is a problem. What weapons do we have to fight back against this enemy then? Well, I'm going to talk through diagnosis and the weapons we have to diagnose infection. Hussein's going to talk through the weapons we have to treat infection. But essentially, like the implements on the right-hand side there, it's pretty rudimentary in both areas of those options. Of the tools that we have in our toolbox. It gets better all the time, but we're still some way off really effectively being able to either avoid, diagnose and treat infection. So you need to know your enemy, and that's really where the diagnosis part comes in. The challenge with diagnosis is mainly twofold. Sometimes it's not a challenge, of course. The picture there is pretty suspicious, I'd say, for infection. Things I can see the hip replacement through the hole, I think. But the questions that crop up is it infected or not? Sometimes that's terribly obvious. Sometimes, and particularly in a chronic setting, it can not be at all obvious, and that's where we can get into a dilemma, or we can even miss the fact that something's chronically infected and mistreat it. And then the other aspect of diagnosis that's difficult is what the infective organism is. To treat an infection effectively, we must know the infective organism, and that can be quite difficult to get sometimes. So we're going to talk about tests you might use, diagnostic criteria, and some aspects of more futuristic or cutting edge tests. So, I mean, I've kept these slides in. I actually gave this a similar talk to some registrars last week. I'm not exactly sure what the audience is today, but it's always worth reminding all of us, including the most experienced people, that we always need to start simple with this. You want a good history. You want to know what implant went in when, how the post-operative course was, did they have leaking wounds, GP giving them antibiotics, were there any concerns early on, and their background, risk factors for infection, and of course their fitness for big surgical procedures that we might propose. The examination is mainly around the wound, of course, any problems with the wound, and whether they've got pain from the joint. And then some basic blood tests and imaging that you'll be familiar with, just normal full blood count, CRP and ESR, just a little reminder there, that's a very sensitive test. The negative predictive value in the literature is usually in the high 90s%. So a normal CRP and ESR makes infection pretty unlikely, unless there's other strong suspicious factors. Blood culture in the acute setting is definitely helpful. If you fail to get a growth and an organism from an aspirate of a joint, at least you've got something probably from a blood culture if they're septic, and that'll help guide your treatment. And then just routine background bloods for their general fitness and other issues. So then aspiration is the real clincher, of course. The aspiration is where we're going to more definitively say, is the joint infected or not? And we're going to work out what the infective organism is. So it's the aspirate that really is our mainstay of our tests. I've written gram stain at the top there and put a line through it. I have to say I don't find it terribly helpful at all. I mean, it's in an acute setting, very occasionally the lab will come back on microscopy that they've seen some cocci, but usually then they'll grow something pretty quickly, and then we've got the actual culture and sensitivities, which are much more helpful. It's rarely that useful. I don't think it's something to put lots of weight on. Certainly if a gram stain is negative, it does not mean that a joint is not infected. Culture and sensitivity is, of course, our gold standard and the ultimate test. Still, really, in 2020, with growing an organism and seeing what antibiotics it's sensitive to is what you really need. You must do extended culture for joint replacements. It sometimes takes some time to grow some organisms. Propionibacter is a classic. And in Northumbria, we culture actually for 10 days. We've got an excellent microbiology team led by Tamsin Oswald. And after looking at it, our local information, she was very confident she could grow everything in 10 days. But sometimes even up to 14 days are needed for extended culture. And certainly your lab should be doing extended culture on all joint replacement aspirates. White cell count on the aspirate fluid and the differential is very helpful. PCR can be a useful test. And there's various other tests as well, of course, on the aspirate fluid. And we'll talk about some of those now. So the white cell count, I do think this can be a really useful test, actually, but only in certain circumstances. If you're really not sure if a joint's infected or not, a white cell count and differential on the aspirate fluid is a pretty good test. It's a very sensitive and specific test. The sort of thresholds we talk about are over 3,000 international units for white cell count or 70% differential for polymorphonucleosides. But there's some debate in the literature about the exact number, but I have to say in practice, I've usually found that a joint is either reassuringly, the white cell count is very low in the hundreds with a clear low differential, or extremely high, tens of thousands with a very high differential. So it is a pretty discriminatory test if you're really not sure if something's infected or not. It's not affected by antibiotic treatment, which can be very helpful if people have been willy-nilly giving antibiotics up to the patient presenting to you. So it's a sensitive specific test on a positive side. Negative side, so we found this when we don't have massive access to this actually in our lab, only on special occasions, because it's pretty time consuming. So Tamsin tells us that the white cell count is a manually done task by a micro technician, and it can take them up to an hour. So it's pretty heavy on manpower in the lab. And of course, you're not going to get an organism. This is just the first question, is a joint infected or not? PCR can be pretty helpful sometimes. Again, it always comes with caveats, of course. So we're very lucky in Northumbria. We've got a Univero machine, which Mike Reed's got for some research in our theatres, which means we do have access to this for clinical cases as well. So PCR tests on aspirate is looking for bacterial DNA against a set panel of organisms. So that's where some of the caveats come in. So we've got the on-site machine. The panel is relatively limited on the on-site machine, and we're not totally sure about the validation for a prosthetic joint infection. We do use it again where we want a quick response and we're struggling, and it can give us it gives the answer in about 5-6 hours. So the classic would be maybe a joint that comes in, a bit of a leaky wound, a little bit of a high CRP about 3 weeks after the op. We're not quite sure whether we want to go as far as surgery. If that comes in the evening and the registrar team put it on the Univero machine overnight, we have a result in the morning. And sure enough, if we've got a Staph aureus on there on the Univero in the morning, it's pretty clear then that we're heading towards surgical treatment. Possibly less so if it's negative. In the chronic setting, we do send some down to London. So some chronically infected, what look like infected joints where we've had multiple negative cultures, then we use a PCR facility in London. Reason being, they've got a much broader set panel that they're testing the sample against for a larger range of organisms. So in a chronic setting, if we're really struggling to prove an infection, but we know really that patient has an infection, then we'll maybe send it down to London. And Great Ormond Street provide an excellent service, but it does take up to a couple of weeks. So on the positive side, the PCR can be fast, the machine in the theatres, but most people obviously don't have the luxury of that. And it does give you an organism. It actually gives you an idea of sensitivities because it will tell you the strain. So for example, a sensitive or a resistant Staphylococcus aureus. On the negative side, it is expensive, the machine, and indeed sending off for the test. If you send it away, it obviously takes ages, so that's not so good. It's only a set panel of organisms, so you can miss organisms that aren't on the machine panel. So that definitely applies to our machine, less so if you go to London because they've got a huge panel. We feel that sometimes it possibly gives us false positive. Essentially, it's just another string to the bow. It's another piece of the jigsaw, and all results for all these things have to be taken in context, of course. Now, how you actually handle the aspirate and what happens to aspirates, we've developed a flow chart to help the on-call teams when they're doing aspirates for acutely presenting joints on the trauma, because people don't necessarily do the right thing if they do get a needle in the joint, get some fluid off, or don't. Not always the right thing happens. What we ideally want from an aspirate is a carefully done aspirate, which produces a nice sample and is sent in the correct mediums to the lab in a timely way so we can get a good response, a good answer to the question, is the joint infected and what's the organism? So to try and achieve that, we've developed this little flow chart. Have you got fluid or not? If so, then the order that we like it sent is actually initially in the blood culture bottle. So traditionally people would put it in a universal container and send it, but Tamsin assures us that blood culture bottles is a much better medium to receive, and it's much more likely to yield a positive growth for an infection. So our order of priority is aerobic blood culture bottle very much first, then anaerobic culture bottle, and if some's left, a universal container. Now in the red box there is the situation where a patient might present relatively acutely, again, maybe with a leaky wound, someone's given them antibiotics. So they've been on antibiotics and the aspirate is on antibiotics. Now, of course, there the risk is that we're going to not get a culture result. We still want the culture as the priority because that's the gold standard, so it goes in the aerobic bottle first. But if they've been on antibiotics, that's when we might send some for our PCR machine, because the PCR will pick up some bacterial DNA as long as it's not too long after antibiotic treatment. It'll still pick up an infection where the culture may not if they're on antibiotics. So that's the only caveat there. Otherwise, we just blood cultures in universal container. Now, of course, the dry tap is the classic. Someone on trauma delegates to the lowest member of the team to try and aspirate. They get a dry tap in inverted commas. So what we say is then we want the responsible consultant who's in trauma to have a go themselves as well. We really need to try and get sample here. If you're wondering if a joint's infected, you need some fluid from the joint to answer the two questions. Is it infected and what's the organism? If you don't get anything from the joint, you're no further on. So it's important that we try as hard as possible to get a meaningful sample. Now, if they also are struggling, then we want some dye in the hip. You need to know you're in the joint. You want metal on the end of the needle. So this is, I'm classically talking about a hip, of course, but it could also apply to shoulder. Maybe the knee is obviously easier to aspirate, but in the hip, we want some dye in the joint. Know you're on the implant. If you've still got a dry tap, we all know it happens. Then we instill a little bit of saline and send and reaspirate that and send it. And the literature tells us actually that's pretty sensitive actually, and it can be quite a good test. The other thing that we have that's very lucky is a nurse practitioner who's trained in aspirates. And Alan Marriott works with us. He does most of our elective planned aspirations. and he's doing up to 200 aspirations a year, so he's extremely good at it, nauseatingly so, I'd say. And his success rate is about 95% for getting fluid out of the joint. So we really use that service. It's very helpful. Something to think of in all your hospitals if you have enough to do, to train someone up to do loads of them, because at the end of the day, none of us are perfect at these things, and he's certainly better than I am at aspirating hips. So the blood culture bottle, there is some literature to back up that idea that you send it in a culture bottle for a better yield, and the sensitivity goes up to 70% there, 90, and specificity 97%. So when you've got the patient in theatre, so if you've gone as far as theatre, just worth mentioning the samples. This is internationally agreed in all the consensus documents that there are out there, American and the BAJIR, the European ones. Send 5 tissue samples and 1 fluid sample from the joint. Not more, not less, always that number. And then with that, you can use the fact that there's 2 positive ones to be diagnostic. You need a dedicated sampling tray of instruments that are clean and separate to take those samples. And you have to be fastidious about doing it. No touching the end of the implants, only hold the hand of the tools, only use the handles. You don't want false growth, contamination. And it should be about a cubic centimetre of tissue, not too much, or you might miss the infected bit of tissue, not too little, or it may not grow. So we've gathered all this information. There's all these diagnostic tests. Where do you go with it? Well, the groups around the world have come up with diagnostic criteria, which is really helpful for us, actually. The first major one was this consensus meeting from the MSIS in 2011, led, of course, by Jay Parvizi, who's the world lead really on infected joints, of course, and you would have all heard of. And the diagnosis of infection in his criteria is based on one of a sinus communicating with the prosthesis, or 2 tissue or fluid samples growing the same organism, and i.e. the same strain of organism, and that equals infection, either of those. What he added, so that was the previous gold standard for infection, but of course, sometimes it's not quite that clear cut. And what he added with these, or the group added with these minor criteria. So if 3 of the following minor criteria exist, then that's also can be considered diagnostic of infection. And that's a raised ESR and CRP, a raised white cell count or leukocyte esterase, a raised differential percentage, which we talked about previously, 1 organism on culture, or 5 neutrophils for high-powered field in histology. Now, we don't have histology, we don't use histology. The department doesn't have enough capacity to provide us with that in our hospital, so that's not that useful for us. Purulence is on there as well, so pus in the joint. So if you're struggling to get a white cell count and histology, that's, it starts to get quite difficult to meet these criteria. But really helpful to add in a further layer there. So if you don't meet the major, but you know it's infected, then we can still conclude that the joint is infected based on that. It's not validated. Some of the thresholds are a bit controversial. As I say, so technically getting some of those tests done isn't available to everybody. It was updated in 2018 by Jay Parvizi again, did a joint paper with the Cleveland Clinic and Rush in Chicago. And they did actually a big piece of work here. They looked at several hundred infected joint replacements and all the tests the patients had done, and did a statistical analysis to weight those test results to help guide us whether something's infected or not. The major criteria remained of those two positive cultures or sinus equals infection. And then the minor criteria were broken down a little bit into preoperative ones based on serum or synovial fluid, and the serum ones, the CRP or ESR. Synovial tests included a white cell count or leukocyte esterase as before, but they added in an alpha defensin because people were using that quite a lot by now. The differential is still there, and they also added in synovial CRP. And they've actually weighted those tests with a score, so based on all their analysis of those several hundred cases. So then you can start to top up your points off that and say, yes, it is infected, no, it's not, or we're still not sure. Sadly, if you're not sure it is infected, you're going to go to theatre, and then you can do, you can add your preoperative score that you've got from those ones to the ones below, positive histology, pus, or a single positive culture, and then hopefully you can reach a conclusive outcome. So he's trying to improve the situation, and then they validated that on a couple of hundred cases actually, and it did seem pretty good. This was their data where they reckon the latest criteria were much more sensitive and specific for being correct. But even this is debated heavily, and it was only done in 3 centres, and it hasn't been widely adopted actually, with probably more people favour the MSIS original criteria actually. Worth mentioning this app if you've got an interest in PJI. It's downloadable on the App Store. It's actually well worth getting hold of. On there is a risk calculator, so you can put in those criteria about infection and it will tell you a score, so i.e. your case is or isn't infected or maybe. But also it's got the whole consensus document from the big meeting in 2018. A couple of friends of mine here who were lucky to be involved in that, Mike Reed and Matt Wilson, Matt from Exeter, Mike from my colleague in Northumbria, and they were among the 40 British surgeons at that big meeting of several hundred surgeons, where really a lot of work was done to look at the evidence behind lots of the infection stuff for diagnosis and treatment, and the full document is available on the app. So the test-wise, to just come back to diagnosis, as you get a feel for, we're still not there, are we? We want the perfect biomarker. We want the holy grail of a test that tells us definitely whether something's infected and what the organism is and sensitivities, and we want the answer within a short space of time so we can make a decision for that patient on the day or the next day, and we're certainly not there. There's loads of possible targets for that which people have researched, but all the studies you have to really take with a pinch of salt. They're often small, they mix acute and chronic, which are very different beasts. It's not just like comparing apples and oranges, but really a full fruit salad. CRP and ESR I've mentioned, obviously in blood. Other things people looked into, procalcitonin, IL-6 certainly looked promising in this paper from 10 years ago and was superior to CRP, but not widely available to us. CD64 shows great promise. Trying to differentiate an acute infection could be really difficult because, of course, the CRP stays high for 20 days. And also inflammatory disease will put up a CRP and ESR. CD64 seems much more specific to infection. It doesn't go up in inflammatory disease, and it normalizes by day 7. So the patient who's coming at day 7 with a leaky wound, we can get an idea if it's raised that might be infection. There's a geeky science slide to show you that the CD64, what we're looking at is a neutrophil receptor, and that's how that works. And that data just shows you that it only peaks in early infection. It's normal otherwise by day 7, unlike CRP. Leukocyte esterase, potentially great little test. Jay Parvizi wrote this paper some while ago. And of course, we've got them all around the hospital. They cost pence. Drop of synovial fluid on the right area of the urine dipstick test can tell you, yes, this is likely to be infected. And it's not bad. It's just 80% sensitive and it's very specific, 100%. But any blood in that fluid, and then it's not really much use. So, you know, hips, often we get a bit of blood in an aspirate, and then you can't really do this test. So it's certainly not the holy grail. Alpha defensin, that came 10 years ago. That was going to be the panacea. Fantastic. There's the data, hugely separate there. You know, it's raised in infection. It's not raised when they're not infected. This was going to be it. This was going to be the solution. That's lab data there. Look at the white cell count. That's not bad, actually. See that Synovial white cell count for the is it infected or not question. Pretty separate, much more of an overlap with the CRP. Also, alpha defensin doesn't seem to go down with antibiotics, so that was looking good too. And normalizes after infection has cleared to help with the second stage, so it was looking pretty good. Outperformed leukocyte esterase when it was compared to that. You do have to note though that lots of these studies on alpha defensin are from Domengian, who works in Rothman in Philadelphia. I was lucky to meet on a fellowship a couple of years ago. But he did a phenomenal amount of work, and it's all very impressive. But he also owned a biotech company and made a significant amount of money out of all this alpha defensin work. So Zimmer came up, as you know, with the Synovusure, which we all got excited about and thought would be the panacea. It's very expensive. You drip a drop of synovial fluid, and then by the pregnancy test lines, you can say infected or not infected. And it was sold as being extremely sensitive and specific. We went through 57 of these and had a little look at it, and it seemed about 90% for sensitivity and specificity. So it wasn't the panacea we were sold, and it's very expensive. We don't really use it anymore. The lab test is probably better. It's not the panacea. So that's taking you through some of my thoughts on diagnosis. It's obviously a huge area, all of this. We've covered a bit of ground. I'm just going to put a case up now to have a little bit of a break from the kind of more lecture style. But are there any questions, I guess, on the diagnosis section?
We have a couple questions that have come in. They may not be specific to, well, yeah, I guess they are fairly specific to diagnosis. So the first one would be, if a patient is not septic, would you advise repeat aspirations of the joint to dryness instead of repeated washouts?
So I think we're talking about a native joint here. So the talk thus far really has been talking about prosthetic joint infection. It's just such a big field, isn't it, that I haven't included native joint really. So that, as far as talking about native joint, it's a very interesting thing, isn't it, that? And in orthopedics, we have the dogma that we have to wash out native joints for infection. But I'm well aware that there are not great, but there are some randomized trials that show in the rheumatology world that repeated aspiration to dryness of an infected native joint, as long as the patient's not septic, can actually be just as effective at clearing infection. And obviously it's not so functionally damaging as doing surgery to them, and certainly is used in some places as treatment. When I worked in King's in London, I know that the rheumatology department dealt with septic joints, basically, unless they were really stubborn and stuck. So I think it is an option, but you do have to do that, repeatedly aspirate them to dryness. And if the patient's septic, you need to wash them out. I mean, I have to say, in our hospital, we tend to take the septic joints, and they tend to get the traditional arthroscopic washout surgery.
That's great, thank you. I just realised I was a voice coming from the ether there, so I'll bring the camera back. No. Next question here. For PGI aspiration, do you make a small incision or do you just stab the joint?
Yeah, I mean, people talk at length about this and have very strong opinions, don't they? We don't make an incision, actually. We do them in theatre. So, well, hips we always do in theatre with proper claw hex prep, drape, sterile field in the laminar flow. And we don't make an incision in the skin. We don't, I would say our aspiration data is very good. We don't feel like we get lots of false positives. So I guess, as always, with lots of this stuff, we can certainly be dogmatic and have strong opinions, but each hospital and each micro lab will perform a bit differently, actually. And I think you have to reflect on your own situation. I think if you don't make an incision and you're having lots of false positives, maybe you should try or improve your asepsis or whatever. So we don't make an incision.
No, I must admit, Tim,
we don't get the radiology department to do them. Hussain, yeah, sorry.
Sorry, contrary to that, Tim, I always make an incision for mine, just from the point of view of not wanting any skin contaminants and the risk of a false positive, and also the concern that if you're aspirating what's an aseptic joint, that you're taking skin commensals and putting them in the joint. So I take a slightly different view to Tim, but I guess it's horses for courses, and whatever your local data would suggest is the best thing for you to do.
I think there's an element of that, because there's no, like much of this, there's no decent literature, so there's certainly nothing on that I'm aware of to guide you. But
I had a question I think would lend itself quite well to what you're discussing there. Obviously, as you mentioned, we've not yet found the holy grail of biomarker. We don't know one thing that everyone should do. But in both of your opinions, do you feel that there should be a standardized sort of protocol of what stages we should go through, or do you think it's important that we all still have different approaches to allow us to find what could potentially be the best option?
So I mean, I think that we should have protocols, yes. They mustn't be 100% rigid, because each hospital will have a different facility. Like we've got the PCR machine. I mean, we're hugely lucky, but most places won't have that. But for 90% of it, we can all agree, the patient should be aspirated, the patient should have early antibiotics if they're septic, that there should be 5 samples from theatre, and so on. So there's a lot we can agree on. And of course, the BASC have come up with their boast on revision knees and infected knees. And this is where we're moving to, having boasts from the BOA and the specialist societies that guide us on evidence-based ways of approaching these problems in a consistent way. In the Northeast, we agreed protocols about 6 or 7 years ago, our infection regional meeting. I think Hussain's got a very similar thing to try and regionally deal with that. And now the Hip and Knee Society are making national guidance, and absolutely makes sense. Hussain, sorry.
Well, I think it's useful. We've done a similar thing in Cheshire and Mersey, but it means that everyone follows a similar process in terms of diagnosis. And then it means for the future, in terms of registries, either a regional registry or BAJIR, which Tim will talk about, that you're actually comparing apples and apples rather than having a more heterogeneous group. I think when I sort of present my talk in a bit, part of the issue with all the research in this area is it's very heterogeneous, and therefore you can't really draw firm conclusions a lot of the time. So a protocol would definitely help with that.
That's great. Okay, we've got a couple more questions. We'll do this few now, and then we'll carry on with the talk. So this one is, what is your opinion in case of a painful total knee with a normal CRP and WBC with clinical suspension of infection, would you proceed to a synovial aspiration and biopsies?
Hussain, your turn.
Sorry, Tim?
Do you want to answer?
Yeah, I think from my point of view, it's all in the history really, and your suspicion in terms of radiographic findings and what the knee looks like. And I don't think there's anything to be lost, particularly given the fact that knee revisions often historically don't do well, then there's nothing to be lost from gaining more information if there's any clinical doubt. Because particularly for knees, I think you're fighting against, issues with less and less bone stock every time a revision takes place, and therefore you want to, sorry to quote a national man, you want to get it right first time, and if that involves taking fluid and synovial biopsies, then that's very important.
So I think I'd probably answer slightly differently. So we don't tend to do biopsies. So we tend to aspirate, and then if we're still unsure, we'll re-aspirate, and then the combination of, by the time you've done a white cell count differential and a culture, and maybe added in a PCR if you're struggling. I mean, I can't think of any cases where we really still then don't know what's going on. So I think it depends what tests you've got available again, doesn't it, a bit? But you do need to be sure. And an indeterminate kind of uncertainty is not acceptable. If you're thinking of committing to a revision, you've got to decide one way or the other, either by repeating the aspirate or if you're stuck, maybe biopsies. But we don't tend to do that, I have to say.
We have multiple questions coming in, so I'm going to pick one more and then we'll carry on. And if we have some time at the end, we can hopefully answer some of the rest of these. So this one states, sorry, missed the start of the talk here, but do you routinely aspirate if CRP is normal?
Quick answer to that, no. If we're lucky, we do CRP and the ASR. I know some hospitals can't get ASR so easily. And in combination, their negative predictive value, as I said, is like up to 98%. So if the CRP and the ASR are normal and there's no other suspicion, no aspirate. If you're highly suspicious and they're both normal, then we might aspirate. But if they're normal, it's very unlikely to be infected, and we don't aspirate routinely revisions. No. Hussain?
Same. Yeah, we're lucky we've still got ASR as well available to us.
Yeah, it does add something though, I think, in the literature.
Sure.
Okay, so shall we carry on and we'll come back to some more of these questions afterwards because they're flooding in here and I know we could get caught up answering questions.
It's a big topic. Okay, so I'm just going to pop up this quick case up just to something a little bit different. I'll try not to be too long, then we'll let Hussain do his talk. So young guy, 42, he presented to our unit a few years ago. He'd had his hip replaced very young, 37, for Perthes elsewhere, and he'd had infection early, and he'd had it managed elsewhere with multiple surgeries, which in the usual way got bigger and more dramatic, and there was fracture and there was infection, and it wasn't great. He'd lost his job. He was on chronic antibiotics, metronidazole, ciprofloxacin. He'd had back dressings on and off. And it's that case at the start there that I put up. This was what we were presented with, seeing him, which is really devastating for a young guy like that, isn't it? So this was a really bad case, a really tough case. Blood's predictably not great, anemic because of the chronic infection, CRP getting higher, albumin really low. This is something we definitely recognize as a problem. I mean, not only does the infection make your albumin low, but then when the albumin is low, that's a real reflection of your body's ability to heal, to fight the infection, and or after surgery to heal. So after infective surgery, wounds can be leaky for quite a long time while that albumin is so low. And it's something that specifically needs addressing. It's not, these patients need very much holistic care. And it's liver functions off, as can be the case with bad infection. These were the x-rays. So he'd had a couple of operations, and that was underneath the infection. So all loose, everything not looking very good at all. So as is always the case in our organisation, everything goes through the MDT. So this is obviously really complex, definitely needs MDT discussion. We have a weekly MDT with micro infectious diseases, the revision arthroplasty team, 5 surgeons, specialist nurse, fellow, a couple of regs usually come, radiology come, we have access to plastics if we need it, and anybody else. And so he was obviously discussed at length, and he clearly needed a bit of optimization. He wasn't septic. I mean, there's a massive hole in his leg, so it's not, a collection of pus, is it? It's draining, and so he wasn't overtly septic, but he certainly wasn't in a good way. So we need to sort his anemia out. He had iron infusion, dietitian input, energy drinks to boost that, try and sort that albumin out, proper TPN wound management run through our dressings service to try and improve the soft tissues a bit. Obviously, we got plastics input, and we were planning basically a two-stage revision with a lot of vancomycin in his in some Palacos for his first stage temporary procedure. So we managed to improve the wound to this, which is obviously a hell of a lot better than how it was. Obviously, the tissues are still terrible, but looking a lot better. Particularly, I can't emphasize enough the multidisciplinary aspect and the diet and all the rest of it. By improving his general state and his anemia and everything, really helps the tissues. So this is the surgery. The bone was dead, there was pus in it, and basically the proximal femur came out. So there was a proximal femoral excision after the implants had all been taken out, of course, thorough debridement of all the infected and nasty looking tissues. We made a temporary spacer from a nail. You can see 50mm syringes with the top and bottom cut off there to make a tube, into which we instilled high levels of, so these days we'd use copal-biminimus Palacos with plenty of gentamicin, with 7 mixes in the end, so there's a lot of gentamicin went in at 2 grams a mix. You can use up to 4 grams a mix, though, of course. And Tamsin off the pre-op samples had told us that it was a Staphylococcus and we were to use Vanc. Always need micro input, of course, to decide what to put in your cement. Sometimes meropenem as well we use, but this was Vanc here. So we fashioned essentially a temporary proximal femur. Plastics, obviously we needed their help, and they did a nice rotational flap for us. That's plumbing in the flap there. And this was the x-ray. So there's the nail, all wrapped in cement, blob of cement in the acetabulum. We've done a Gillstone type procedure for this because it was pretty nasty and horrible. Nearly always we try and put something articulating in, but this is really quite nasty, and that's what we did here. And sure enough, it still grew sensitive Staphylococcus, so that's okay as far as the micro goes. But the flap started looking a bit dusky after a few days. And then, believe it or not, the plastic surgeon brought in his leeches. So this is an unusual side that you won't see very often. And sure enough, leeches were applied, and the flap did manage to survive and come back to life. And he healed up. So he recovered from that first stage. These days, he'd be on the bone infection unit for a long time with us, getting specialist nurse attention, getting dietitian help, getting 2 or 3 times weekly micro review, ID review, and discussion every week in our revision MDT. But then he was just on the normal ward. The wound settled anyway. Aspirate was negative. After 8 or 10 weeks, his bloods returned much more to normal once we cleared that infective tissue that was making him so unwell systemically. Remember, the guy's not old. And there was a plan to proceed to second stage. So he had a link proximal femoral replacement, which worked out well for him for a fair while, but the guy's not old, and there's a relatively short segment, of course, of fixation there. You can see he's a fairly chunky patient. And after having 4 good years on that and racing around the place, sadly, he came back with 3 months of distal thigh pain, and the stem had come loose. Good news was the infection had still gone. So now, isn't it just so much easier to deal with at least just a mechanical problem? It's when you've got infection as well that your heart truly sinks. And he had negative aspirate, normal bloods. There was no sign of infection at all, but the stem was loose. So we went on, did another operation, and he ended up with what was then a link tailor-made. I mean, Sean maybe can tell me now, but I believe that it doesn't have to be in your tailor-made range, this, but you certainly do tailor-made implants for specific patients for specific problems. But you got this made for Mike, who actually did the second stage, and that's a big uncemented stem there. And that one, now we're about 8 years since that, and he has been fine. But it's again that classic thing, you know, he started off with a normal primary hip replacement, young guy, and because of infection, he's ended up like this in his 50s. This is a bad place to be. Okay, I'm going to hand over to Hussain now.
Great, thanks, Tim.
Fantastic.
Great. So thanks for the invite along, Sean and Tim. I'm Hussain Kazi. I'm an orthopaedic surgeon in Cheshire. I'm going to talk about prevention, and then I'm going to talk briefly about treatment. Obviously, it's a huge topic, so it's a bit of a selected view of things, really, and a run through. And then I've got a couple of cases to show before Tim does the final bit of this evening. So I'm going to talk about the prevention side of things. And my key message and it's particularly pertinent given the last case really, is that you want the right patient with their risk factors and comorbidities managed, the right operation with a high chance of success, and longevity being a key thing to think about, as well as what you may leave for colleagues who may need to go in again after you. And then at the right time in terms of their symptoms, disease profile, and that they're optimized preoperatively. So pre-op, males are at higher risk. Obviously, people with comorbidities, particularly diabetes and steroid use, are at higher risk. Smoking is terrible. And then blood parameters such as the nutritional status, which we'll talk about in due course, and then pathogen eradication as well. So in terms of smoking, it's an addiction like many others, but as a disease, it's treated and stigmatized very differently to other diseases. And patients, generally speaking, don't benefit from just being told to go away and give up smoking. There is a benefit from them giving up, though, both in terms of their joint replacement and their risk of it failing, and also in terms of their long-term health. Varenicline is one option for this, which is actually approved by NICE now. So there was a paper in the Lancet getting on for 20 years ago looking at hip and knee replacement, and with those patients who had smoking intervention to give up prior to surgery with help and assistance, then there was a significant reduction in wound-related complications, cardiovascular complications, and reoperation, and as well as length of stay. And that's got to be a good thing, I think, from our point of view. In terms of screening bloods, you need to look for anemia and correct it, or find a cause for it. Think about their endocrine function and then the nutritional status, and look at their albumin and LFTs, as Tim has alluded to already. Because if a patient has low albumin pre-op, then they will do badly and they will have wound complications and issues with infection. And you don't want them to be at high risk when you start. You want to try and optimize that beforehand. The other thing that I always talk to all of my registrars about is looking for any infective foci they may have pre-op. So be that skin lesions on their legs and calves, between their toes, and particularly for the obese patient, looking in their groins to make sure they haven't got any trigo. Because you want to reduce the risk of any fungal or bacterial contamination, and particularly in relation to fungal infections in terms of a joint replacement are a nightmare to deal with. And they've got a much worse outcome than those which are bacterial in nature. On the day of surgery, we're going to use chlorhexidine preoperatively for a few days beforehand to decolonize the patients. And there have been ongoing studies looking at MSSA decolonization as well. And I know the QUIST trial led by Northumbria, which we were a recruiting centre for, are going to report their outcomes in due course now that the trial has finished. But bear in mind that a lot of trials need lots of people and lots of patients to try and show any difference. And because infection is such a heterogeneous group, that sometimes trials may not show a difference, but your common sense tells you that something is a good thing to do. And the thing to bear in mind is that MRSA and MSSA are absolutely devastating for patients. Temperature, both preoperatively and during their procedure, is really important as well. Hypothermia leads to increased complications from a cardiovascular point of view. But also from a point of view of infection risk, there's triple the risk of having a wound site infection if the patient's hypothermic. I think the Northumbria group have already shown concern using forced air ventilation. And from my point of view, I don't use any forced air warming in theatre, I just use conductive apparatus and insulation of the patient. And the reason for that is the concern with forced air warming creating a vortex which is in the wrong direction to the laminar flow, and it drags stuff up off the floor and into the wound. And that's been shown in numerous studies, both in the UK and elsewhere. The Rio study looked at cemented hemiarthroplasty for fractured neck of femur, and essentially they were looking at forced air versus conductive warming for patients. But they showed you need a trial of almost 9,000 patients in order to detect the difference between fabric warming and forced air. But I look forward to that being taken on and the results of it, because I think that'd be a very useful thing to do, but obviously big numbers concerned. But the point of pre-warming is that it means the patient's at the right temperature when they hit the anaesthetic room. And I know that our in-house audits we've done in my unit, the anaesthetic room is where the real temperature drop occurs, because the patient, particularly for a joint replacement, normally has neuraxial anaesthesia, so they're exposed. We spray their back with cold stuff, and then the anaesthetist is stabbing in the back with a needle. It only takes between 5 and 10 minutes to do it, but at that point the whole back is exposed and they're losing heat from an evaporative point of view. You can't really warm them other than what they're sitting on, and what you can wrap around their body. So it's a key thing to have the temperature as high as it can be before the spinal goes in. And then the higher it is when you start, the less the drop will be in theatre, essentially, and that's shown quite nicely on this slide, really. But the difference in the two lines is whether you have pre-warming and whether you have warming intraoperatively as well. So it's very important to consider that. Other things that have come to light are that betadine irrigation can be useful in terms of reducing your wound infection rate and your deep infection rate. And there's been numerous studies from the US which have shown that. Part of the issue with using betadine in the UK is that the stuff that we use for skin prep is not sterile. So you need a supply of sterile betadine that has to be mixed in theatre. And then if you're going to follow the study protocol and you have to leave it in the wound, around the implant for 2 minutes, which often seems like a long time. From my point of view, in my unit, I found it a lot easier to use what I used in Exeter on my fellowship, which is this dilute chlorhexidine acetate. I irrigate when I do a hip after I've done the socket, and then I irrigate again after I've done the femoral side and I'm closing, and I leave some in the joint for both hips and knees when I'm closing at the end of the procedure to try and prevent that biofilm from forming. Whether it makes a difference to the biofilm or not, I can't tell you, but what I can tell you is that when you look at the research on this concentration of chlorhexidine, it's got the optimum concentration in terms of kill rate, but also minimal complications in terms of tissue toxicity. And that's quite important, really, when you want your wounds to heal up afterwards. Tranexamic acid, another very important thing in terms of reducing bleeding and subsequently reducing your wound ooze and therefore issues with hematoma and infection. And there's good evidence now that you can use 20 to 30 milligrams per kilogram without an increased risk of VTE and cardiovascular complications. This slide is just demonstrating, really, in terms of infection management, that there is a synergistic effect of having 2 different antibiotics in your bone cement. So if you've got a high-risk patient, particularly someone who's had previous septic arthritis or other issues with infection, then I'll often use dual antibiotic cement, such as Palacos G and V, or G and C, depending on what the profile of the patient is. But there's certainly very good evidence for using dual antibiotic bone cement in terms of your infection management when you're operating on someone for infection, because you get much higher levels of antibiotic within the wound, and therefore you're more likely to reach your inhibitory concentration of antibiotics within the wound and the tissues around the wound. A lot of the, I've not touched on too much on anemia and MSSA, but suffice to say that there are issues that you need to grapple with and consider. And I look forward to the outcome of Northumbria's QUIST trial in due course. So in terms of the actual treatment of PJI, this is the battlefield. This is the place where we go to try and do right for the patients. But it's quite challenging psychologically from the surgical point of view, and it's incredibly challenging psychologically, as you've heard, from the patient's point of view, particularly with that very pertinent patient video that Tim showed at the start of this evening's events. But in general principles, I've stolen this off my limb recon surgeons, really, for their open fracture management, but I think the same principles apply for an infected joint replacement. You want to sterilize the area. You need to stabilize it so the patient's got something stable to walk on, and then stimulation. And what I mean by that is stimulation in the area where the infection's been in terms of antibiotic release and delivery, but also stimulation at the interface between the implant and the patient, so that you maintain their bone stock and their muscle mass, so that their function is as good as it can be in the future. So antibiotic-loaded bone cement I've already talked about, but it's been used for a long time in the treatment of periprosthetic infection. And this is just a slide showing an infected primary joint replacement being managed in the process of management with a 2-stage procedure using antibiotic-loaded beads. As per the technique described by the Sheffield group, and Sheffield group with Ian Stockley and before him Reg Elson were really at the forefront of development of infection treatment and protocols, really. This early paper by Reg Elson shows a rather novel basic science experiment where you have a femur here with cement down the middle of it with antibiotics inside it. It's sealed off from the outside world with wax, and then there's water in this pot above it, and you can detect antibiotics in that. So in other words, there is antibiotic elution from the bone cement, and that goes through the bone and into the local area. So it's actually quite a good delivery system for sterilizing the bone and the soft tissues as well. This is similar to the slide I showed earlier, just showing the synergistic effect and elution rates of having 2 antibiotics in bone cement rather than 1. So I'd strongly encourage use of antibiotics, both appropriate to the organism you're treating, but also to use dual antibiotic therapy within the bone cement, either in terms of proprietary mix or mixed in by hand yourself. The evidence from the Sheffield group is that mixing by hand yourself and mixing in air actually gives you much better elution than if you use a proprietary system of antibiotics in your cement. However, that creates some technicalities for you in terms of obtaining the antibiotics and also mixing them in theatre. This is a paper from the Oxford group looking at DARE, so debridement and implant retention. And Oxford are very big on this. They've published on it quite widely. And essentially that's patients who have an infection where you open up the joint, debride things, change any components that can be changed easily, and then suppress the infection with long-term antibiotics. Now, that might seem a very tangible proposition initially, but the difficulty with DARE is that it has a recurrence rate, and that recurrence rate actually, when you look at it, is relatively high, and it gets higher when you stop antibiotics. And a lot of these patients are immune suppressed, they've got comorbidities, and if they're on antibiotics long term, they can have issues with their kidneys and also marrow suppression and that sort of thing. And if I was a patient, I'd rather be off antibiotics if at all possible without an infected joint. So that's sort of the start of your treatment ladder, if you like. But it is an option for patients who don't wish to have radical or major surgery, where you think there's a decent chance of success. The other option, of course, is a 1 or a 2-stage revision. That's a debate that's been had on an ongoing basis as to which you prefer. Tends to historically be of which camp you came from and where you trained. But if you actually look at this meta-analysis, which is over 8 years old now, you can see that actually the difference between a 1 and a 2-stage in terms of infection recurrence is actually not too much. And therefore, there's the possibility that a single stage is actually quite a tangible proposition. A 2-stage revision, for the patient's point of view, gives them a short leg, it's painful, it's tiring, they have 2 operations, and they need an awful lot of help in terms of getting around, mobilizing, and continuing to live a day-to-day life, and that's quite difficult for them. And then for the surgeon, it creates issue with scar tissue, limb shortening, risks to nerves and blood vessels when you go back in. And also from my point of view, if the bone's not being loaded, if we remember according to Wolff's law, then you have a reduction in bone stock, the bone is soft. And from my point of view, the more the bone is loaded and the more the muscles are activated, the better state the patient will be in, and the better the soft tissues will be in when you go back in again. So the Exeter group described this technique of preservation of the original femoral cement mantle, and they initially came across it in a 2-stage revision, whereby you can see in figure 1b here, there's a very well cemented femoral component. Subsequently, there's been issues with infection, and a 2-stage revision has been embarked upon. However, the well-fixed femoral cement in the canal has been preserved where possible. And the means of testing that intraoperatively is by doing the blade test. So you visually inspect the cement at the cement bone interface when you're looking down the femoral neck, and put a surgical blade at the interface between the two. And if a blade won't go in, it passes the blade test, and we can consider that biological interface to be intact, and therefore no bug should have got down there. You can then ream up the femoral cement mantle if you want to elute more antibiotics, and then use that for cementing cement revision either at the same stage or at the 2nd stage. So that's an option for treatment rather than digging out the cement from the femur. And that works provided you've got antibiotics in that cement and the organism is sensitive to them, essentially, and that's something to consider. Prostalac was originated in the US using molds essentially to make a temporary spacer in order to try and make the patient's life better, so they had something to articulate with. It wasn't initially licensed in Europe or available in the UK, and the group in Exeter had a problem in that they wanted an articulating spacer, but they didn't have access to a Prostalac. There was a Kiwi fellow working for them at the time, and who suggested essentially just coating a normal implant that you might use for a primary hip in cement, and then utilising that as a temporary spacer. I've just got a short video to show you here of performing this sort of procedure. The key thing to bear in mind when you saw the initial image of the video there is that the surgical bed is all bleeding. So in other words, there's been a really good debridement performed so that there is no dead tissue there at all. There's then extra antibiotics added into the cement, and then the cement is mixed in air without a vacuum to try and increase its porosity. There's bleeding bone and bleeding bed, and then your implants are loosely cemented in. So in other words, you're not doing a full-on pressurization like you would do for your normal primary hip replacement. And then once the acetabular cement has gone off, then you can perform a similar procedure on the femoral side, but rather than plugging the canal and then gunning cement down the femur, you're simply just going to coat the implant in cement before putting it down. And I have some images of that here now, which you can see. That's just marking off the broach depth. But you can see here the cement is actually pretty viscous by the point in time you're doing this. The stem is being coated in cement, and then the stem is going to be put down the femur and essentially molded to the femur to the right depth. But again, you're not having that pressurization created so that you're getting a macro interlock at the cement bone interface. And you can see here the stem's just being driven home. And then in a second, any excess cement will be removed and the stem will be removed, and then remold that cement around it so there's no metalwork exposed. And then you can put it down the femur again, take it out again and remold it again. And do that repeatedly until you reach a point where the cement's becoming pretty rigid, at which point then you can leave the stem in situ at the depth that you want to put it down to. And you can see here just being put into its final resting place, ensuring that there's axial stability and also rotational stability. But you'll see there's a slight bit of movement there, and the theory is that that helps to elute some more antibiotics at the time with the movement taking place, although it needs to be rigid enough for the patient to mobilize on. The results of this have been published, and they are relatively variable in that some of the patients needed conversion to a second stage, but a lot of them didn't need conversion to a second stage at all. And I've got several patients like that myself. However, towards the end of this series, they were tending to do a more full-on proper pressurization of the cement, and therefore the results were actually better in terms of fixation and satisfaction of the patients. So in terms of our options, you've got excision of the joint if the patient's not a candidate for reconstruction, which I almost never do, although I've got a case to show you in a moment where I've done it. There's a two-stage, a kiwi, where you can't quite make up your mind, and then a single stage. There's been the INFORM trial going on nationwide, which is a randomized trial of two-stage versus one stage, and the results of that will be published in due course, and will be very interesting to see. Really how I've adapted my practice in recent years, provided I've got sensitivities and I'm happy, is to try and do what I call a 2-in-1, which I'll talk about in a second, really. So in summary, polymer bone cement is an organic substance and it's a useful antibiotic delivery system. You need to have heat-stable antibiotics. You can use up to 10% antibiotics by mass. Articulating spacers can improve both your life and the life of the patient. And in selected cases, a single stage is appropriate. So I'll just present this case of mine of what I call a well-fixed kiwi, really, which is really a single stage by another name, I think. So this lady is 74 years old. She had hip dysplasia as a child and then had bilateral pelvic osteotomies as a young adult. She had a right total hip that was in the 70s, and that was revised in the early 2000s. And then she had a left complex primary total hip in the early 1970s. And she was referred to me because the left hip was making noise and becoming slightly more painful, although she still wasn't really happy to get rid of it as she was quite attached to it. But when she came to see me in clinic, she told me, I've just developed this hole on my right side, which has been discharging serious fluid for the past few days. So those are her radiographs. You can see on the left side that she's had an acetabular reconstruction. This is in the early 70s with relatively rudimentary implants. She's had a Charnley stem on the left side, and that was done in 1970 with radiolucent cement. And I saw this lady 3 years ago, and that Charnley stem's still going strong. On the right side, she obviously had a revision. There's the screws in both acetabuli from her osteotomies, but the right side is the side with the sinus draining. So from my point of view, she obviously needed investigation. I did her bloods, which showed a CRP of 70. Listed her for an aspiration, and I aspirated her several times and never got any positive cultures back. However, on her aspirates, when the cytology came back, she had a white cell count more than 5,000. So I was happily convinced with the sinus, the raised CRP, and the raised white cell count on her aspirate that she was infected. And so I had a conversation with her about her options. She lives alone. She's very independent, does her own gardening, her own cooking and cleaning. She was unwilling to accept a 2-stage unless she could have a spacer that would function well enough for her to live at home. And she wanted a single operation, and definitely didn't want to have 2 operations on the right hip, as she knew she would already need surgery on the left hip at some point as well. And I extensively counselled her regarding those options, and she was keen to try a single stage, which for me didn't sit very well because I didn't have any positive organisms for which to direct my antibiotic therapy, really. So I had some concerns. So we opted for a halfway house, which is me really saying I would do a kiwi. I templated and planned for that, as I think you should for all primaries and all revisions, really. And then subsequently performed her surgery, and essentially that involved a radical debridement and removal of loads and loads of fibrous tissue and scar tissue, removal of all the metalwork I could get my hands on without destroying her femur, managed to get the metalwork out of her acetabulum, and then did a thorough debridement, wash out, lavage, lots of saline, checking back again, making sure all tissue was bleeding, and then a temporary wound closure. Got rid of all the drapes and all the equipment from theatre, then re-prepped and re-draped, and then performed her implantation. You'll note that I left the femoral cement in zone 2 and 6 because that was well fixed. It passed the blade test, and I thought it would be more destructive in a very small tight femur to remove that cement and leave her with a patulous femur that I wouldn't be able to bypass. So I took that risk intraoperatively, and I talked to her about that beforehand, having anticipated it. On the acetabular side, I used Palacos with 4 grams of vancomycin mixed into 2 mixes. And then on the femoral side, I used Simplex just because I'm more familiar with using that for cement and cement revision, and mixed extra vancomycin with that as well. And subsequently, her culture showed staph epidermidis. That was sensitive to vancomycin and Tyco, and our microbiologists made an initial plan of 6 weeks of IVs, but we managed to reduce that significantly as her CRP fell very rapidly with the debridement. And then I put her on oral doxycycline, which she was sensitive to as well, once her CRP was less than 50. And then by the end of March 2017, her CRP was less than 5, and we finished antibiotics at the 3-month point. And that was in October 18, and she's remained asymptomatic from the point of view of that right hip. Tissues are well healed, and her CRP is less than 5. And subsequently, I went on to revise her left side, which was simply aseptic loosening and wear of the acetabular component. And she's continuing to do well. And these are our latest radiographs in October 2020. I've got one more case to show you, which is a 75-year-old who I looked after back in 2019. She was independent and self-caring when she came into hospital, mild memory impairment, ex-smoker. She'd had a total hip replacement by one of my colleagues 2 years prior to coming in to see me, but she'd had a constrained cup as she was developing dementia. And she had a fall and was unable to weight bear, and she's had a significant periprosthetic fracture. I think Tim will probably agree with me that a lot of the patients who have a periprosthetic fracture have some degree of comorbidity. So they've either got medical issues, memory issues, or balance issues, and it's normally a sign that things are slowly unraveling in their life, unfortunately, a lot of the time, I think. You can see I'm sorry, Tim?
Sadly, their neck of femur patients with a hip replacement in.
Exactly. I mean, that's the most succinct way of putting it, probably. You can see from her radiographs that she's got a fracture that's extending distal to her canal plug. It's comminuted. Because she's got a door C type femur, there's no real isthmus. There's nothing that you can put a sort of cone or scratch fit uncemented implant into. In the region that I live in and work in, we don't have really great support from a company who makes a distally locked stem, which are really in vogue for treating this sort of fracture nowadays. But we do have good support from Link. So with cases like this, I've used the Link MP cemented revision stem, which you can see with the radiographs here. And essentially it's a distally cemented stem. It's got a really neat sleeve that goes over the stem when you cement, so you don't get any cement over the proximal bit, which is uncemented. And it's allowed me great length, so I can bypass the fracture. You can see the fracture is being reconstructed with some cables. We've got really good cementation distally, so I'm happy with the stability that she can weight bear and walk on that. And then I did a cement and cement revision on the acetabular side to another constrained cup, essentially. Because she's elderly and frail and her albumin was low, I also used a pico dressing, which you can see the box for here, which is just a vacuum assisted dressing to try and maintain her wound dryness, essentially. And afterwards, she got on pretty well, mobilized quite well, and her wound healed fine. But unfortunately, over the next 2 months, when she was on the rehab ward, she developed a contracture of both her hip and her knee. Manipulation was attempted by physio. One of the rehab physicians attempted some Botox into her hamstrings, but it didn't really function well to any avail or attempts of us to try and sort her out. And the feeling was that she'd really developed some ischemic contractures and that probably her vascular inflow wasn't that great, in spite of the fact she had decent femoral pulses preoperatively, and that she was probably relying a lot on collateral circulation. And the dissection I've done at the time of the surgery, as well as tying off her perforators, has maybe led to some borderline ischemia, which has worsened over time. And she did have very calcified perforators intraoperatively. You can see that she started to develop this flexion contracture of her knee, and then subsequently got an adduction and flexion contracture of her hip, and then you can see a really big flexion contracture of her knee, unfortunately. I scanned her spine to make sure she didn't have any pathology in her spine or any infective pathology, made sure she didn't have any neurological diagnosis by getting an MR scan of her brain. But sadly, she then went on to develop heel necrosis. She was reviewed by one of my good vascular colleagues who felt that she wasn't really good for a below knee amputation. He didn't feel her foot or leg was salvageable, and his preference was for an above knee amputation. But obviously she's got this stem going most of the way down her femur. And from my point of view, that was going to be a bit of a technical challenge. Unfortunately, then she started draining pus from her heel. And then next thing, she became unwell, and her wound over the hip became red and inflamed and then burst pus out of it. So at that point, we really didn't think things were salvageable at all. I took her to theatre and aspirated her hip, and sadly, she had MRSA in her hip joint. And I think it was a combination of the heel necrosis, infection in the heel, and then hematology spread into her hip, and then everything has fallen apart, unfortunately, as her physiological reserve was poor. And sadly, we had to take the choice of considering her life greater than her limb. Her limb was not salvageable at this point, and so unfortunately, she ended up with a hip disarticulation. But with that, thankfully, you still have a stump for balance. So she still had decent muscle mass from her knee flexors, of what were left of them, in terms of creating a flap out of those. I reamed out the acetabular component after disengaging the constrained hip, and then subsequently freshened up the cement with a burr to allow some antibiotic delivery within the stump itself. And I put a collotamp sponge, which is a bovine sponge, which is impregnated with gentamicin fleece in there to dissolve and try and sterilize the area. And thankfully, her stump healed very well. And she's still able to sit out in a chair and transfer on one leg, lives in her own home with carers and support from her daughter. So although the outcome is not what I'd have hoped it would have been, functionally, she's actually not as bad as I thought that she might be with this, what I feel is pretty barbaric treatment. I'll leave it there anyway. I'll let Tim carry on. Thanks.
I would just like to say a big thank you to both of you for those talks. We do have quite a few questions that have come in. I'll obviously try to work through a couple of them now. I am conscious of time, and we still want to get our update on the bone and joint infection registry as well. Are you guys happy if we work through a couple of questions quickly just now, maybe take 5 minutes or so, and then we can move on with that? So a couple of logistical questions. First, I'll sort of couple them all into one, and that would be, how do you send your fluids for white cell count and PMN, and any recommendations on which needle you use for aspiration?
So I use a spinal needle that's of the biggest diameter we can get, really. We had an issue recently in that our anaesthetists started using different spinal needles. And so we managed to get some which are hollow stainless steel spinal needles, which are not for use for a spinal anaesthetic, essentially. But I tend to use those. I tend to use a small volume syringe, because I think big volume syringe create too much pressure, too much vacuum. So you tend to suck any cavity closed, so you can't aspirate very easily. In terms of our local resource in Cheshire, we've got, we did have a guy who's now Dean of Manchester Medical School, called Tony Fremont, who's a professor of synovial pathology, and we send our fluid samples to him for cytology, and they go in a paediatric lithium heparin pot. But the lab in Manchester, it's based at Manchester Royal Infirmary, and they'll send a box through the post to your unit. So from anywhere in the country, you can send synovial fluid samples to them, and they'll look at them, do a very accurate cell count, but they'll also tell you about bits of debris, whether there's aseptic loosening or whether there's evidence of infection or not, and they're very experienced at doing so. Tim, have you got anything to
that sounds interesting. So if we want a white cell count, we can do it in our own lab, although not lots of them. As I said, it's time consuming and a bit difficult. But if we're stuck and we want a white cell count, we put it just in an EDTA bottle, so a purple top full blood count bottle, and send it down to the lab like that, and they can do a white cell count and differential off that. It just needs to be not clotted, basically. The other stuff that Hussain has access to sounds very good, and kind of regionally based labs are interesting. There's a kind of Zimmer lab in Glasgow that's going to do lots of different tests. That sounds a bit interesting, but you know, it depends what you need. Sometimes things are more straightforward. You don't need the specialist stuff. Aspirate needle, yeah, the biggest, you want an 18 gauge ideally. You want a decent gauge to get the fluid out. If it's too narrow, you can't get anything out. It's hard to get the right ones.
That's great, thank you. Sorry, cutting you off there, Tim. We've got a comment rather than a question here from John Phillips down next to, and he's letting us know that they are about to submit a paper demonstrating that biopsies found different or additional organisms in 29% of cases. That was looking specifically at knees. If either of you would like to talk to that at all, any comments?
I mean, from my point of view, whenever we're working up an infected knee, we generally always do a scope and biopsies. But that's just a view we've taken as a department, really, to try and increase the yield. Yeah.
Sounds interesting. I look forward to reading
it. This question was quite specific, Hussain, to when I think you were showing the concentration of fluid that you use in the joint for killing bacteria and minimizing soft tissue damage. And it stated, did the NICE guidance not ask us to stop using irrigation? Is leaving it in the body a good idea?
Yeah, so Tim and I were talking about this last night in preparation for this very talk. I mean, it's always difficult when NICE make comments like that. And I think the problem with infection is that it's a relatively uncommon occurrence, thankfully, and feels like it's getting less common. And the concern for me is when you've worked somewhere, like, you know, both Tim and I did fellowships in Exeter, where it's been, that strategy has been used for a long time, with probably the lowest infection rate in the country, or at least one of the lowest. And then the concern is when NICE say something like that, because there's no evidence for it, it makes me sound like a bit of a heretic saying this, but the concern is that you then stop doing it, and then you start having more issues with infection, really. Yeah. I mean, essentially, Matt Hubble likens it to being dental mouthwash, really. Essentially, is what it is. And it's of a lower concentration than dental mouthwash as well. So realistically, I don't have any major concerns about carrying on using it. Although I understand and appreciate that it may be off license, so to speak. But no, it doesn't fill me with any major concerns, because I've been using it for a long time. Yeah.
It's a risk-benefit situation a bit, isn't it? The problem is infection is so awful, as we've just said, that, you know, yeah, the risks are very low. The benefits maybe are high, but we don't know. The literature is so poor on all these things, we don't know the answers.
Sure. Okay, I'm going to ask one last question here, and then I'll hand back over to yourself, Tim, for an update. In regard to duration of antibiotics, if CRP drops to normal in 6 weeks, do you still continue with antibiotics?
So we stop. We do 6 weeks of antibiotics. We do relatively short intravenous and an oral switch relatively early, usually after about a week. And then, sorry, there's just some screen sharing thing. We do antibiotics, yeah, IV for about a week on the bone infection unit, and if they're responding well, they go to oral. And we stop the antibiotics always at 6 weeks as long as they're responding. Occasionally carry them on a bit longer. Streptococcus is the exception. There's literature that suggests up to 6 months of antibiotics actually is much more effective for Streptococcus. Andre Trumpaz from Berlin, I think, came up with that information. So Tamsin makes us give the strep infection 6 months of amoxil.
Yeah, my strategy is similar to Tim, really, but I mean, I'm mindful of the fact, Tim, there was that paper in the Journal of Arthroplasty earlier this year showing that 3 months 3 months antibiotics reduced your need for future revision. But I think, again, often with these things, looking at a very heterogeneous group, and therefore it's difficult to ascertain particular benefits of one strategy or over another.
It's all very difficult, and there's risk benefit. You know, Tamsin, whilst giving us antibiotic advice, also is this week running her antibiotic awareness campaign and trying to limit use of antibiotics to solve problems with resistance and so on. So, I mean, I'll briefly do a BAJIR update, but that's why we need the registry to answer these sort of questions. We need a lot of national data, and then we can start to look at some of these impossible questions that you can't answer in one organisation.
Absolutely. Well, yeah, Tim, like I say, you've got the screen there. We will let you move on now with our BAJIR update, and then we will wrap it up for this evening once you're done there. So thank you.
No problem. So, so yeah, so we've told you a bit about infection there, why it's the enemy because of the huge cost, the difficulties in diagnosis, and what's the future going to hold. You know, hopefully we can be better at fighting this arch enemy. Cost-wise, I think we have to use MDT's protocols, like you mentioned in one of the questions, which is a really good point, and start to get consistent management. People talk about revision centres, maybe not that, but at least regional agreed protocols for managing things like they have in Mersey, I think is an excellent plan so that we can improve the management. Diagnosis, we're waiting for that holy grail biomarker. One day it will come, I'm sure, but we haven't got the ideal test yet, as we've just been discussing. And treatment-wise, we haven't got the ideal answer either, have we? It's huge surgeries that are destructive for patients. We've been finding out a bit about bacteriophages, and they're fascinating, but that's for another day. It's a big topic. So bone and joint infection registry, this is another way we can fight this arch enemy is with data. So infection is complicated because it's so heterogeneous. The numbers are small, so no single organisation can come up with good data to guide us on how to investigate and manage infection. And it's all about the power of data. So as a country, if we can put our data together, then we can actually start to answer some of these questions properly with decent quality data instead of individual organizations coming up with contra kind of opinions based on small papers. So this all started with NHS England. They came up with a bone and joint infection specification in 2013 because it's so expensive to manage and such a problem, and they wanted a registry. And BAJIR was formed by Mike Reed. I have to just mention Andy Sprowson there, who's sadly obviously no longer with us, but Andy was one of the instigators of it, and people behind the idea of the bone and joint infection registry. So who are we interested in? So in the bone and joint infection registry, I mentioned at the start, sorry, but I'm the treasurer, so I definitely want you to come and join and help this project. So we want any bone and joint infection, basically, long bone osteomyelitis. We don't want diabetic feet though. There's a lot of diabetic feet. Foot and ankle crowd have got that under control. That would swamp the registry. We don't want that information. But otherwise, any long bone osteomyelitis, native joint septic arthritis, spinal infections, a bit of crossover with the spine registries, which we're still discussing with them. But then the mainstay, of course, is prosthetic joint infection at the bottom there, and that's a large quantity of the bone and joint infections. So we've got this section 251 consent. Some of you will have heard these talks before. Again, sorry, I'm not sure exactly what the audience is, but we've got a presumed consent, so patients can be identified with bone and joint infection and entered into the database. And we've got a whole 18 months to gather their explicit consent, in which time we can keep their data and look at that. and that's granted for things that are in the public interest. Other kind of registries like hip fracture database use it, and we've managed to get that for BAJIR, which was a hell of a lot of work for the guys who helped set this up, but really is a good thing, and we have to refresh that every now and then. So we collect a load of data. We want data. We take the bone and joint infection registry is detailed. There are a lot of screens. There's a lot of information to enter because, you know, we've just been talking for an hour and a half how complicated infection is. So you need a lot of data to get some meaningful answers. So that means it is quite time consuming. There are a lot of screens and we need a lot of information. We gather in the database information on the patients, on their treatment, both medical, i.e. antibiotics, and surgical, and some comorbidities and so on. And it's based a little bit on we have to give credit to the Oxford bone infection database, guided a lot of the structure of it, right? But we need a lot of information, so it is time consuming. This lady is crucial to the bone and joint infection registry. Angie Kingman is our head of admin and proms lead, and she's been with the project since the very start. And so she's there in the background, steering the ship and using the database. She's done loads of work with the IT guys, the Dendrite who've developed the software, because it constantly needs improving, tweaking. You know, they're data guys, they don't understand clinical work, and she's a great go-between. She helps us with the reports, the data governance. It's Angie that pursues the patients for consent within 18 months, and if we gain their explicit consent, then we can use all of their data forever. If they don't give us consent, you can still use some of the data, but it's obviously then anonymized. And she does the PROMS collection, so she'll send out the PROMS form so that we get PROMS as we move forward. So if you enter your patients in BAJIR, you have to get initial PROMS for us, but then we will provide PROMS EQ5D as timescales as we move forwards to see how patients are doing. So we do that work for you for free. We've got 16 trusts now signed up, ready to enter data and entering data, which is fantastic. They may not be exactly accurate, that list, but there's 16 signed up now. There's a whole load more double figures working busily to get the governance support, and we want more trusts. We want more cases, because that's what's going to make all this worthwhile, and we can really answer some of these impossible questions. This was yesterday, 205 confirmed infections. There's another 400 patients in the registry, maybe waiting confirmation of infection, i.e. within the registry, you have to confirm that they've definitely got an infection based on maybe, you know, 2 positive intraoperative samples and so on, or that they haven't. So there are other cases in there, and that is going up quite quickly now as everybody comes on board and starts putting data in. So we're getting cases into the database now, and then we can do some really exciting stuff, which of course is analyzing the data. So far, we haven't really been able to do that. We haven't got long enough or quantity enough of data, but we're heading there quickly, and it's good. And we always had this vision that, you know, you can look at things like first-time DARE, and you can look at over as a country how successful that is. Patient survival, how many patients die, what are PROMs like, maybe 6 months, 12 months, 2 years, and you can look at loads and loads of stuff. And then as you get more and more data, you can really drill down into it, which you can never do as an individual organization. The questions like, how do you perform with DARE with individual organisms, or with individual antibiotics, or calcium sulfate, stimulant, people chucking in left, right, and center, but there's very poor evidence for it, actually. It's because it's impossible to research, because you need those massive numbers, like Hussain said before, and of course the registry can help us with that, and we can make some progress. This is just a very brief early data, but this is some EQ5D data we've got for 6 months for hips and knees, and a bit later as well, after they're there, and you can see the hips do much better after infection than knees, EQ5D wise. So we're going to start to get some output of data, and we've already got national reports on the website, but they're pretty rudimentary, and as we move forward, we'll really start to produce some interesting stuff, and we can really do lots of research through it as well. We've got fellows now. So I have to mention, thanks to the industry, so far it's entirely funded by money from industry, no government money or NHS money. Link have been hugely helpful. That's why I'm bringing this up in a Link talk. They've been sponsoring us. And our financial future is secure for the next 3 or 4 years, hopefully through that. But I personally feel that we need NHS support. The Revision Knee project was going to be a great way to acknowledge in the NHS that some money needs giving to this complex stuff to help manage it properly. All this data is going to be hugely powerful, improve the quality of treatment and improve the cost effectiveness of treatment. And the NHS should be helping to support us so we've got a secure long-term future. But in the meantime, industry have been fantastic at helping us. So there was a whole load of challenges when the project started, but essentially this is probably the only positive story in 2020, I think, in amongst the COVID nightmare, is the BAJIR is working, it's up and running, everything's sorted out, it's ready to put data into. We're putting loads of data in Northumbria, and we're gradually getting units on board, starting to put data in, and then we can start to answer questions. The knee revision group have been really helpful. If John Phillips is still there, he's at least got a little bit to do with that, and that's been great because there's talk about that in the knee revision post. Hopefully the hip one will have the same, and we want to push to a national agenda to put your data in BAJIR so we can really start to progress. Final little push, we've developed this MDT software because we realize it's an onerous thing, putting all this data into the BAJIR and time consuming. We want something to give to you to help you make it worthwhile your while using it. The MDT software we've developed, so all the patients you put in BAJIR you can have on an MDT list for your meetings, so they can be in a pending queue, just monitoring if they need keeping an eye on, and then each week you move them over to the active list. You make a list of patients that you're going to discuss that week and open their MDT file, which looks like this, which has a bit of background in, comorbidities and so on, the problem. There's a box for the discussion that happens at the meeting, and then an outcome, which is, you know, out of the MDT process now, or we still need to discuss them next week, or in the monitoring box. And it also will produce, sorry, this is very rudimentary outcome, it's going to look better than this, but you'll get a document of the discussion and the conclusions that you can print if you need, if you're old fashioned, and put in the notes, like we still have paper notes, or an electronic PDF version that can go into an electronic note. So there's a record for the notes as well as the discussion. So essentially you can run your infection MDT practice through the bone and joint infection registry. So we can give you the facility to do that through the MDT software. You can give us the data so that we increase hugely the amount of data and we can really make progress. So hopefully that will help persuade some of those of you who aren't yet in to come and join us. So we need you, we need your data, and with that we can answer some of these tricky questions. So I'm going to wind up there. Thank you very much for listening to us. We've gone on quite a while. It's such a big topic. There's so much to talk about. And thanks to Link for sponsoring us and getting us together to talk about this. Thank you.
Thank you very much for that, Tim. I would just like to comment that you gave a big thanks to Angie Kingman there, and she's actually on the webinar with us this evening. So I will just second your thanks there and say thank you to Angie for the hard work that she's been putting in to help drive this project forward. So I'm glad she got a chance to hear that. It has been a precarious year to say the least, and we've had a lack of meetings in person. So I'm glad we have the opportunity to do things like this, and certainly from the team at Link, we want to say a big thank you to both of you guys for taking time out of your evening to give these great talks, and a big thank you to all of our attendees as well for taking time out of their evenings to tune in and listen to us. For anyone that is interested or wants to share this with any colleagues or friends, all webinars do become available on our website, which is linkorthopedics.co.uk/events. And that will be up in a couple of days after this, so you can watch back any of the content. So, gents, I would just like to say once again a big thank you for all of your time, and yeah, I look forward to us hopefully being able to catch up in person soon enough.
Thank you.
Thank you. Excellent.
Thanks very much.
Good evening.